depressed about the fact they've been ill. It's when they're sane, usually okay, and when they're completely psychotic, okay. It's the movement between the two which brings about the depression.
Albo kompletne szaleństwo, albo wyjście z szaleństwa, no ale wtedy świadomość szaleństwa i depresja.
Siegel emphasizes the importance of trying to help the psychotic patient integrate their experience and make contact with depressing realities about the nature of their illness. She believed that this could bring about therapeutic development and growth. However, she also points out that inevitably to manage this can provoke negative therapeutic reactions that threaten to overwhelm the patient's ego again and bring further fragmentation and severe negative therapeutic reactions. The problem is that the patient's psychological health depends upon his capacity to make contact with emotional reality, which causes the sort of psychological pain the individual can't bear. And in this way, the patient is caught in a catch-22. Siegel outlined the need for a particular clinical setting that supports the therapeutic treatment. She emphasised the need for access to inpatient facilities which allow the treatment to continue in the event of the patient being admitted to hospital. She also made the point that a failure to establish a sufficiently robust setting often contributes to the failure of treatment. This certainly tallies with my own experience of treating patients with psychotic conditions. The treatment's chance of success is enhanced by good psychiatric support. The case I'll now describe below took place in an outpatient setting as part of a specialist outpatient psychotherapy service. Importantly, the patient was also under the care of a psychiatrist in the community and had a family that supported his treatment, which lasted over a number of years. Mr. A took antipsychotic medication during the course of the treatment, and there was frequent communication between the unit and the psychiatrist responsible for his psychiatric care. I treated the patient with psychoanalytic technique that I use for patients with all kinds of psychopathologies, which involves trying to identify transference communications from the beginning of the therapy. My aim of this approach is to support the patient in bearing psychic pain and reducing the reliance on violent projection, which also helped him develop a self-reflective capacity. Mr. A is a 45-year-old man at the time of referral with a diagnosis of paranoid schizophrenia and a history of drug and alcohol abuse. During his 20s, he'd been admitted to hospital on several occasions in violent psychotic states of mind, admitted under section. These admissions ceased after he discontinued his alcohol and drug abuse in his late 20s. His parents divorced when he was 4, his mother subsequently dying when he was 20 years old. He had no contact with his father following the divorce, although he was aware that his father had subsequently remarried and had more children. Mr. A had a close relationship with his aunt, who he said acted more like a mother who supported him all the way through childhood. He said he was aware that he never really fitted in at school and became more isolated as time went on, eventually dropping out of high school. He had a series of manual jobs before falling into drugs and dropping out. He had his first admission under section in his early 20s. Through different stages of his illness and rehabilitation, his aunt encouraged him to attend a day centre and paint every day to work towards his dream of becoming a professional artist. He felt painting helped him synthesise his experiences, and he thought success in this area would enable him to support a wife and family and live a normal life. A community psychiatric nurse at the day centre provided emotional support as well as practical advice. During his psychotherapy, he took a small dose of antipsychotic medication. And he continued throughout this treatment, which is about 7 years with me, he continued to attend Alcoholics Anonymous occasionally. Progress of the therapy. Mr. A attended his therapy on a regular basis, although he frequently complained that he had obsessive compulsive disorder and spent long periods of time preparing to leave his flat. He was unable to leave home in a hurry as he had to manage the fear of panic attacks. My patient found any gap between his expectations and reality difficult to manage. Any experience of frustration tended to produce violent reactions, which he tried to control by cutting himself off. He had a rigid gait and way of moving, which gave the impression of that he was a robot. He described emotional storms that threatened to overwhelm him, and he explained to me that while I described him as having feelings, he felt he became the feeling and lost any sense of being able to observe himself. I want to describe how he would enter the room. Okay, he would walk in a sort of very sort of schizophrenic gait like this. He would then take his coat off and he would put his coat in the chair next to him with the hood, so it was sitting up as if it was another person, and then he would sit here. I felt like I got two people in the room, one in the coat and the other in him. But this changed a bit over time, where he became more fluid and human in his movements. But anyway, I might...
Troszkę się to zmieniło, jak zaczął być taki bardziej płynny i ludzki w swoich zachowaniach.
Okay. So, where did I get to? Yes. At the start of each session, he'd walk into the room and give me a blow-by-blow account of the upsetting moments of his week. It was as if these moments had been stored up inside him until he could evacuate them, and I often felt like I was caught in a meteor shower, as if he wanted to give me an experience of what it was like to be him. Bombarded by raw experiences, these appeared to be, there was no expectation from him that I would have any interest in thinking about the meaning of these experiences. The first session I would like to describe took place a few months into the start of therapy. At the start of the session, Mr. A complained he was dominated by his obsessional-compulsive disorder, which meant he spent hours preparing to leave his flat to come to the session. I said I thought he was worried he was going to be contaminated by things I might say in the session, and this would interfere with his way of seeing and thinking. He replied to this by saying he thought he made such a fuss about things, having exaggerated responses rather than just responding like a normal person. I was conscious of a fleeting moment of pain as he said this. He went on to say he'd gone to a fancy dress party at the day centre, dressed as an alien. He said he'd won a lot of compliments for his costume, but then he worried he wouldn't be able to get out of role. I said I thought although he got excited by his ability to withdraw into an alien world of his own, he then worried he'd get stuck. Mr. A said he thought I was right and rushed on to say that he'd been asking himself why he felt so comfortable as an alien, going on to say how angry he felt when he realised He'd stayed up watching television until late. He watches Prison Break all night. The voices started to comment on his behaviour, saying that he should have gone to bed earlier and that he'd been stupid. He then cast spells on the voices, but he didn't make any difference, so he ends up punching the wall and screaming at the voices, "Fuck off and leave me alone." Mr. A responds by saying this had been going on for 20 years and now he thought it might never end. He became angrier, saying that the voices implied he couldn't decide to go to bed without being prompted. The discussion of the first session. I often had difficulty thinking about the material in the session, but recovered my capacity to think about the material afterwards. The session starts with a description of the difficulty Mr. A had in leaving the world he controls through his OCD in order to come to his session. I thought this showed his painful awareness of his difficulties, and this was quickly followed by the story about the alien costume. Here he shows the excitement at being able to withdraw into an alien world and so evade contact with painful reality. I think the costume that pleases him is the belief that he can control the contact in the session by playing the role of an alien man who's detached from reality. It's as if he believes he's in control of his delusions, a costume he puts on. However, Mr. A then gets into a panic. He can't get the makeup off. It's as if he's stuck in his alien costume. This panic reflects, I think, the breakdown of his belief that he's in control of his psychosis, namely that he's a sane man acting as being psychotic. This causes momentary feelings of despair, but he seemed able to respond to my comments about the way he gets stuck in an alien world. The psychotic part of Mr. A's mind then doesn't like being observed as he becomes aware of his empty state of mind caused by the psychotic defence. I think his anger and cursing is directed at me, as if he feels I want to get into the costume of a sane patient and exclude the psychotic part of himself. This brings a technical issue, which is a constant challenge with this kind of patient, that it's easier to talk to the sane part of the patient, but this leads to the psychotic part feeling excluded and unwanted. Sinnerson and Richards developed Bion's theory regarding the non-psychotic and psychotic part of the personality, developing a clinical approach based on the idea that the psychotic patient contains a self that recognises the need for others and a self that feels threatened by relationships and yearns to establish a sense of self-sufficiency. They describe the former as the patient and the latter as the self, and the latter self as the internal cohabitee. The ego is believed to be completely split between these two distinct aspects of the self. Therapists are encouraged to think about the dynamic relationship that exists between the patient, the cohabitee and the therapist. They emphasise that the cohabitee may feel threatened and excluded by activity between the therapist and the emotionally available patient. This can lead to acting out, which may be interpreted as a negative therapeutic reaction or an attack on the therapy, when in effect it's provoked by the cohabitee's feeling of threat and rejection. Mr. A felt that pressure on him to be sane excluded the psychotic part of his mind that felt threatened by the therapeutic relationship.